Good morning, everybody, and welcome to this edition of Macro Pro and Friends. Today, I am joined by Carrie Robinson. Carrie, are you there?
I'm here.
Hi,
Hi.
Carrie. How are you?
I'm well. How are you doing?
I'm outstanding. So today is the 1-year anniversary since the state of California called the stay-at-home order. So how has it been for the last year for you and your company?
I think it's probably been the same for a lot of people. It seems like Groundhog Day is never ending, but obviously getting out with the vaccines and different things going on in the industry. For work-wise, it was tough at first because surgeries weren't happening, physical therapy wasn't happening, all of those things that MedRisk does. And so we had a really hard time, but we had already had telerehab in place. So a lot of it shifted to telerehab. We bumped that up. We got more physical therapists on staff and did all the things we could to shift a lot of those injured workers to telerehab as opposed to the traditional in-house physical therapy services. So that worked really well. And we're noticing an uptick of people staying in telerehab, the convenience of all of that. So it's really nice to have that capability.
There is a silver lining in all of this pandemic. So before we get started, I wanted to introduce myself. For those of you who don't know me, I'm Diane Cohen. I'm Vice President of Client Relations here at MacroPro. We are a document retrieval company. We secure records for claims and litigated files. So regardless of where your records are, whether nationwide or worldwide, MacroPro can get those records for you. I have a little bit of housekeeping that I would like to take care of before we get started. The first thing is your certificates will come to you via email tomorrow. There'll be a little blue button. It'll say your certificate is here. Please make sure you download that tomorrow. We are not provided copies of those certificates, so you want to make sure that you have it and you keep it in your file for your records. However, you do have a problem downloading it, send that original email to me and I will download it for you and send it back to you. Secondly, if you have any questions, please be sure to put them in the chat portion or the question portion of this webinar, and Carrie and I will be happy to ask the expert the questions at the end of this program. There are handout materials that are attached to this webinar, so please be sure to download those so that you have a copy for your records so you can refer to them in the future. And then lastly, there is an encore performance of this on the MacroPro YouTube page. So look for that next week if you'd like to see this again. So Carrie, can you introduce your speaker for us?
I'm happy to. Today we have Dr. Marciniak joining us. She is the National Director of Clinical Services for SPNet, a division of MedRisk. She has been licensed in physical therapy since 1994 with a clinical focus on industrial rehabilitation, and she completed her doctorate in physical therapy in 2018. She has since presented over 300 times to various audiences on topics focusing on worker safety and patient rehabilitation. Her full bio is on the screen and part of the presentation, so if you'd like to read that, it's available to you. So thank you, Dr. Marciniak, for joining us today.
Thank you. Can you hear me okay?
I can hear you.
Okay. Wonderful. Well, welcome all of you and things. Like she said, I am a physical therapist, so I will attempt to get through this a little bit early if there are questions. I want to save time for that. There is a chat function that you can ask them. If you don't ask enough questions at the end and we still have time over, obviously as a therapist, I will make you exercise or sit up really straight in your chair. So, be wise about that and those sorts of things and ask questions so you don't have to do exercises at the end. We're going to talk about chronic low back pain. I am very, very pleased that so many of you are on today, given the fact that this is a challenging and a very daunting topic. So just a little bit about what we're going to talk today and how chronic low back pain is one where a lot of times the specific diagnosis is questionable. We don't know 100% what structure is involved or what's causing it. It's not like the knee where you can say, well, it's an MCL or an ACL and let's just fix it and everything seems to be great. There's a lot more challenging factors. Surgery sometimes can happen and not really fix what's going on or fix what's causing the pain. So surgical intervention outcomes often are not quite what they are in other joints. Residual symptoms are often, they try to address them with long-term medication. And anytime you see the word long-term when it comes to claims, obviously that will increase your costs and inability to close out claims and resolve them speedily. With all the advances in healthcare, unfortunately, there hasn't been a huge improvement in disability prevention. So we've come a long way with technology and diagnostics, but unfortunately, low back pain is still a problem and affects a lot of people and drives a lot of costs in the industry. So kind of objectives for today, give you a deeper understanding of chronic low back pain, identify modifiable factors and cost-effective solutions. So, you know, it is a challenge. What can you do about it? For me, I always I had asked Diane and Carrie earlier on what's the target audience, who's going to be on, and what do they want to know, and kind of my personal goals for this is to give you not only that insight, but also talk a little bit about why you might get practice variation. Why is it that one person is in therapy for 4 or 5 months and one person is better in 1 to 2 weeks? What is the difference? Why does that happen? As a therapist, that's always something that I focus on, especially in my clinical review responsibilities. And then the second one, as they said, now that we're rounding the corner with the 1 year since COVID, there will be a day sometime soon that we can go to parties again. I want to make you smarter at parties. I want to give you some tips that you can talk about and make you sound really smart. So there'll be a couple. I'll point them out. I'll wave my hands as I tell them to you, but I will give you some good stories to tell when it comes to low back pain, everybody's favorite topic. So what defines chronic pain? When we talk about chronic low back pain, what does that mean? And if I take a step back real quick, let's talk about what pain is. The IASP, which is the International Association for the Study of Pain, came out with a new definition of pain within the last 5 years. And they indicated that pain is an unpleasant sensory and emotional experience associated with actual or perceived tissue damage. So there's a lot of loaded things in that. It's not just a sensation. It's not just, oh, there's a pin in me, ouch, that hurts. It's also an emotional experience. The parts of your brain that are associated with pain are also very, very close to the emotional centers. So as human beings, we can't separate the two. And then it's associated with actual or perceived tissue damage. So you don't always have to have your arm on fire to have it be hurting. It can be a perception that there's damage. Again, these are real. It's a person-to-person experience. And according to the AMA, the American Pain Association, the only way to measure pain is to ask the person, do you hurt? How much does it hurt from 0 to 10? That is the measurement strategy. It's not on MRI or other things. So it's there. It's real. From a chronic standpoint, usually the most simplistic way of looking at it is it's a duration of longer than 3 months, or it could be pain that persists longer than the expected period of time for healing. So if you have a low-grade sprain, usually that's something that resolves within 1 to 2 weeks or up to 3 weeks. If you're still having pain 2 months afterwards, that could be considered chronic for that injury. A little bit about the spine. You are not in a therapy lecture until we start showing you pictures of bones and things. I used to have my little spine that I took into a different industry when I gave things. It was especially fun when I did the flight attendant training classes and I got to run the back through the x-ray camera. The TSA people would always bring over the trainees and say, look, she's got a body in her bag and things. But from a nomenclature standpoint, the spine is made up of 24 individual vertebrae. There's 7 in the neck, which are definitely smaller. There's 12 in the mid-back or the thoracic spine. These don't move a whole lot. Most of your thoracic spine motion is back and forth and forward. You don't have a lot of extension. There's 5 in the low back, and then there's 5 that are fused together in the sacral vertebrae. Probably the weakest parts of your back, and this is where you'll also notice the most injury. The cervical are numbered 1 through 7, so C7 and T1, thoracic 1, C7, that is where you see a curve going in, changing to a curve going out. That's a weak spot of your spine. So the majority of cervical issues happen down here. Same thing with the lumbar. This is L1, 2, 3, 4, and 5. The majority of issues come in between L4, 5, and L5S1 because you're going from a curve this way to a curve the other way. That is just a weak structural point of the spine where you carry a lot of stress when you're lifting or bending or doing those sorts of things. So a little bit about the structures. Here are your vertebrae sitting on top of each other. In between those is the disc. These are the facet joints in the back. They're kind of a weight-bearing joint, especially in extension. If you extend back, you load those facet joints. And then this is just an example of a herniated disc where it pushes out into that canal, and that's where all your nerves run, which is why a lot of people get what they call radicular pain down the leg. What could possibly go wrong with the back? Well, 85% of low back pain is mechanical or musculoskeletal, we call it. It may be from a muscle, ligament, a tendon strain, disc disorders, spondylosis or spondylolisthesis. Those are when the back shifts on each other, again, stressing all those soft tissue structures around it. That's the vast majority of it, and definitely what we see more often than not in the work comp population. Other things that can cause low back pain, rheumatologic, infectious, bladder infections, kidney infections, both can refer pain into the low back. So therapists are trained on kind of medical screening procedures. When people come in, we always have people fill out past medical history, and we'll do a quick health screen just to make sure that we're ruling out any other things that can be contributing to these. But it's a consideration also if people aren't feeling better, aren't getting better, or following normal patterns for musculoskeletal pain and what you would expect. Epidemiology, 20% every year has back pain. So out of the over 100 people on the call, probably 30 to 40 of you have had back pain so far this year and things. Again, I encourage you not to sit through the whole presentation. Stand up, walk around, move, and those sorts of things. From a work comp standpoint, a lot of times we think this is, half or 2/3 of the cases that we see. A lot of times that's because they're the higher cost ones. Over work comp in general, there are about 8.8% of claims. We usually see between 8 and 12% a year, but that's of all claims. So obviously they're much higher. They're usually number 1 or number 2 when it comes to the body, the position or body type. Shoulder is up there, but low back certainly is usually the top or second place. Medium time to recover is usually 7 to 8 weeks. So the majority of these get better before they ever get into that chronic phase. The odds of having continued low back pain for 12 weeks is about 35%, and up to a year is 10%. So these can happen, and again, that's kind of the majority of what we're going to talk about today, is how to try to avoid getting into that chronic phase. That's where all the issues. 75% have 1 or more relapses. That's why patient education is so important, so that when they do get a twinge in their back 6 months down the line, they don't think, oh my gosh, it's happened again, I'm not going to be able to work, those sorts of things. Relapses happen, back pain happens. It's something that they can get better and get over. I find this definitely, again, like in the knee, a lot of times where we can easily identify a structure. If you've ever watched sports, the person falls down in football and they kind of will say immediately, oh, it's their ACL, or it's this, or it looks like they tore their Achilles tendon. We don't have that luxury with the low back. There's so many different structures in there, and they all overlap, and they all do very, very similar things and refer pain in the same ways. So diagnosis of low back pain is unspecified in 80% of the patients. 80% of the people that we see come into PT, their primary diagnosis is low back pain, not disc, not spondylolisthesis or degenerative disc. It's just low back pain and things. Specific diagnosis is possible, not just with an MRI or diagnostic imaging, but with doing special tests and narrowing down the scope. We can differentiate between muscle, joint, and ligamentous structures, mechanical versus systemic disorders and things. A lot of times what we do in therapy is we categorize by clinical symptoms. So we look at trying to subtype, not as much what specific structure, because we don't always need to know that in order to treat it, but what cluster does it follow? This is where sometimes when I bring in the bones and all different technical terms, I start to lose people. So what I found is I will tell you a story about my three-legged aunt. My Aunt Ida, who's actually my dad's aunt, she had an amputation of her leg back in the 50s. And when they used to do leg amputations in the 50s, they would give you two legs. One was to wear every day, and one was to wear for dress and special occasions. So the first time I ever met my aunt, she had taken the dress leg out of the closet, and she'd put it in between her other two legs, and she'd covered herself up with a blanket. So my 7-year-old self came in to meet her for the same time, and I took one look and saw the three legs shooting out from under the blanket. My face lit up, and she started laughing, and we were close ever since. She might be part of the reason I wanted to be a therapist and things. But after she had her leg amputation, she had foot pain for a good year. Her foot hurt. It wasn't there anymore. She didn't even know where her foot was and what happened to it after the amputation, but her foot hurt. That is, from a classification symptoms and things we look at, that would be more of a peripheral nerve issue, where it wasn't the foot. Even though she was having foot pain, it wasn't anything to do with the foot. It was something to do with the nerves that were up the line. They'd been severed, and that caused the brain to think, oh, my foot hurts. So is the pain local? Is it something to do with that structure or issue right there? Is the pain peripheral? Or is it more of a central issue? Is it more of a somatization or a stress response to things that can also cause pain? So if you subtype, it will help you look at what am I going to do as far as treatment. Again, knowing that that's a peripheral issue, we could focus on the nerves further up her leg. I wasn't going to put a hot pack on her foot that wasn't there and say, oh, you'll feel better tomorrow and things. So subtyping often can improve therapy, help focus the direction. Diagnosis. Again, there's a lot of anatomic abnormalities in asymptomatic individuals. Essentially, we're going to go into that a little bit when we talk about diagnostic testing, but at least 50% of the people on this call have disc bulges in their back. They've looked at people even without any symptoms that have never had back pain. You have degenerative changes in your back, and you have disc things going on. So it's not always helpful to get diagnostic testing, especially in the very beginning. There can be inconsistent physical findings. They can have pain in different places based on the day, because there's a lot of nerves that go places. One of my favorites is non-specific therapy is effective. There's a therapist that I work with here locally in Cincinnati, and he coined a phrase, movement is improvement. So if all else fails, moving around helps you feel better. So movement is improvement. If you can get them moving, in a safe and educated manner so that they're not putting stress on their back, but able to move and get those good effects, that is half the battle with treatment and things. So again, non-specific therapy, aerobic conditioning, aerobic exercise, general mobility programs, those tend to help with this 85% of people that have mechanical low back pain. Somatic and neuropathic and radicular pains, they can be differentiated. Again, that's one of those typing systems where we look at what is the pain generator type, and then we can look on that. And again, it's difficult to identify, hey, it's this specific facet joint on L4 on the left side and things like that. But often we don't need that in order to treat them or make them better. So again, unfortunately, the trends right now in the industry is we're doing more diagnostic imaging. We're doing more MRIs and CTs and EMGs and diagnostic studies. I haven't had one person that walked out of a MRI or EMG and went, oh gosh, I feel so much better now that I had that, and those sorts of things. They're not treatment-based. They don't help them in things. Increased incidence of surgery. We're doing more injections. We're prescribing more opioids. Definitely, we've seen a huge shift in that over the last few years. Increased costs for low back pain, but again, not a significant decrease in disability. So this must be important because it's huge and bright letters and things like that. So one of the things to kind of shift and look at is no imaging or other diagnostic testing is needed initially in a patient with non-specific low back pain. So a lot of patients immediately will think, well, my pain is 8 out of 10, so I need an MRI. And things. It's not as much how bad the pain is, it's how you hurt yourself, your characteristics as far as age and comorbidities and things, and then what type of symptoms you're having, not how bad. So I think a lot of times we're conditioned in the American medical system and with AFLAC. I found out a coworker of mine was like, oh, I get a check for $100 if I get an MRI. I'm like, well, then of course you're going to want MRIs and things. So a lot of the systems and things like that make us designed to say, oh, well, I want this or I want that or I want a name for what's going on. So at least in the very beginning, diagnostics and diagnostic testing is not bad, but in the very beginning, if it's a non-specific low back pain issue, you don't have to spend a whole lot of time with advanced imaging or MRIs or CTs or those sorts of things. Here's one to focus on. Here's when to get them. So if you're trying to make good decisions on where to spend your healthcare dollars and things, if they have a high risk of a vertebral compression fracture, that would be somebody that fell from height and crashed down. They fell off a roof or something fell on them. If they have a high risk for a compression fracture, get an x-ray, oftentimes there might need a CT scan or something like that, but you want to rule out the cause if they have a fracture, not for safety. If you have suspected infection, cauda equina, or any progressive or severe neurological deficits, this could include if the patient starts to complain of any bladder or bowel issues and things. Those are ones that typically you want to rule that out because that can be a sign of significant nerve damage, which isn't always reversible. So if they have risk factors for cancer, again, that is something that a lot of times you have to separate out from the work comp claim. But if they've had any of the symptoms of cancer, I know through the American Cancer Association, there's a list on their website of 8 or 10 to look for and things. It's just something you want to rule out because, it can be a significant safety factor for treatment. Suspected radiculopathy or stenosis if they have severe or progressive neurological symptoms. Neurological symptoms aren't just it hurts in my leg, it will usually hurt down a specific pattern based on where that nerve runs. So it's not just that the pain goes here because those can follow myotomal or muscle patterns. And again, you can consider an MRI or CT after a month. If you're wanting to screen them for either surgery or epidural. So the MRI should always lead to a treatment planning or some sort of treatment solution rather than just giving a name to something. Most people, again, the natural history of low back issues is that the majority of them should self-regulate and refer back with conservative treatment within the first couple months. If that's the case, then we don't need advanced imaging on those. So save it for the people that need it. When it isn't, imaging helpful, again, when they're getting better anyway. If you are not suspecting any serious underlying conditions, their past medical history is clear, all other risk factors are not there. Again, it can cause harm because that person's doing relatively well with therapy, and then all of a sudden they find out they have a bulging disc, which again they probably did before their injury, and now they can't get better. They had an uncle that had a bulging disc and he had to have surgery and he didn't go back to work, and those sorts of things. That is what lends itself often into fear avoidance behaviors, which is I can't do anything because of my pain, anxiety, kind of catastrophizing, which is making the back condition a lot bigger than it is. Again, many of the diagnostics don't have an impact on what we're going to do treatment-wise with the patient. So you want to increase the likelihood of any unnecessary or potentially harmful intervention. So you don't want to do a surgery or injection if it's not going to fix the actual issue that they're having or what's keeping them from being able to work and function and do things. There was a study back in 1990, and this has been replicated over and over again. They took 67 normal subjects. Those were people that were having absolutely no low back pain at all, and they did an MRI. But in the less than 60-year-old population, 22% had herniated discs, 1% had spinal stenosis, 54% had bulging discs. Again, the majority of people do, less than 6 years old, and then 46% had degenerated disc, which is just the lowering and squishing of the disc. Over age 60, a third of people had herniated disc, 80% almost had bulging, and 93% had degenerative. Again, none of them had back pain, which kept them from doing anything, but they had these positives. So again, be judicious, because as you know, a lot of times we don't have a snapshot of what they looked like before they came. So suddenly they fall or slip or go to lift something and their back hurts. All of a sudden, this is yours. You own this now, because the assumption will be that it happened on your watch. Is imaging overused? There have been some studies that show that, a third to up to 2/3, especially that are ordered by primary care physicians. There was a Medicare study also that was done that replicated that, and then 28 to 38% of California work comp MRIs were inappropriate. So maybe ones on cases that you had seen where you said, well, that didn't really necessarily get me anywhere. They are finding that a lot of times the physician may do it based on how bad the patient feels, how much pain they're complaining of, or how much time's gone by, which again, there's also higher use. We see this both with physician-owned PT practices, physician-owned MRI facilities. They're going to tend to refer often. It's the Oprah, you get an MRI, you get an MRI, you get an MRI. Everybody gets an MRI and things, but you can't drive them like a car. So not necessarily the best thing. Imaging hazards, again, the minute that you label a patient, you're saddling them with something, you're putting weight on them and things. It's like a heavy pack sometimes. Then they have to carry that around, and it can be something that keeps them in a barrier to their recovery. So we want to definitely avoid that within their rehab process and helping them to get better. So just some conclusions on diagnostics and things. Again, more advanced imaging, more surgery tend to have the same amount of outcomes. Diagnoses are often ambiguous, and again, serious diseases are rare. There's definite signs of compression fractures, cancer, the other things. History and physical can often rule out those issues or identify red flags where you do need diagnostic testing, typically avoiding imaging in the first month unless you have a significant neurological thing, or again, they fell, they had a fall on them. Sometimes it'll be a slip and fall in somebody that's over 50 because, again, you get a lot of false positives with imaging. So reserve a CT or MRI for somebody that may potentially be a surgical candidate or there's some other suspicion to rule out. Treatments, again, so we've talked a little bit about diagnostic and those sorts of things. So also we look at treatment. I threw these up there. I think all of these were advertisements for different treatment things. I consider myself a decent therapist, and a lot of people like to make claims about percentages. Whenever I see a percentage, I always remember the quote, 58.3% of statistics are made up and things. So if you ever see anything where they say, hey, mobilization or this traction device or with this, 80% of people get better, take it with a grain of salt. 80% of our candidates got better with this surgery or this new device that we bought and those sorts of things. The reason that you should be choosy about that is 80% of patients get better anyway without any treatment, without any other thing. Is 80% of people with low back pain regress back to the mean. Now, it's difficult because you can't, and that usually takes up to 7 weeks. You don't want to take your injured worker and say, go lay down at home for 7 weeks because you know it's going to happen. You have to pay them to be at home. Then they get tight and weak and deconditioned and all these other things happen. But again, there is a natural history to regress back to where they started. Hawthorne and placebo effects are essential. If we do any type of treatment, you're going to get some sort of a treatment effect on that, and you'll think, oh, I'm getting better. We used to, as a therapist, one of the clinics I worked in, we wore white coats because we thought that patients got better if we did. The more doctory we looked, then the more we thought they got better and believed in the process. So again, you may not be getting specific or true effects of treatment. It's all over there. Read into the fine print a little bit of some of those things. The American College of Physicians, they did put out a guideline recently about low back pain, and this is great to see for the industry as a whole, that the physician groups are starting to really recognize that there are issues and that we want to move in certain directions with how we care for patients and how we prevent people from going to the acute into the chronic back pain issues. A couple of the things from this study that were important, one was the emphasis on non-pharmacological therapies, so more conservative therapies, your PTs and things like that, particularly for chronic low back pain, instead of just long-term medication. Can we get them into a treatment and therapy program? Really strong cautions about opioids. We're going to talk about that a little bit more with pharmaceuticals in general. Acetaminophen no longer recommended for acute low back pain. There are actually more liver transplants in the U.S. because of acetaminophen or Tylenol toxicity than there are due to any other cause. So they're trying to get away from recommending acetaminophen. More evidence on mind-body interventions and that psychosocial piece. It's important. It's something that's coming. So just looking at general wellness and how much that can help people get over pain issues and things. Identify and address risk factors for chronicity. I've been a PT for about 26 years. I used to run and was the treatment director for a chronic pain program that we did in conjunction with pain management physicians. Always realize that it's very, very important, people's psychosocial outlook on their pain, of how much they get better. That has gained some traction over the years. In treatment, it used to be 20, 25 years ago, you couldn't even mention anything that had the word psycho in it because they thought that it was a psychological definition, and please don't say that my people are depressed or anxious. That's outside of my scope of practice to diagnose any of that, but I definitely can look at behaviors like fear avoidance or self-limiting or pain catastrophizing, and those sorts of things. So what we've tried to encourage with therapists in general is to go from just a biomedical issue where it's your joint, it's your muscle, it's your nerve, and look more at the whole picture of biopsychosocial. How is that joint, that muscle, that nerve impacting you in general? If you're afraid to move around, what does that do to your whole central nervous system to where you're making that pain worse? How can your attitude or how you look at therapy and how bad it is, and if a patient comes in and says, I don't think I'll ever return to work, they're technically not going to do, and typically aren't going to do as well as somebody that says, oh yeah, I can get better with this, I've had this before, and those types of things. So being able to identify and address those psychosocial factors, again, we're not putting a label or a diagnosis on it, just being aware that has a big part. And they found, research has shown that psychosocial can become just as critical as biomechanical programs or physical work demands after that first 1 to 4 months. So as you're getting from that acute into the subacute, it's very important to at least be conscious of these things. One thing that we use in either therapy initial evaluations or MedRisk has a PT consult program where we'll actually call in and go through. There's a musculoskeletal questionnaire called the Arabro, and it does ask the patient, how they feel about returning to work, how they feel about their injury, will they ever recover, and it kind of gets their thoughts. It breaks them into, are you fear avoidant? Are you catastrophizing the problem? Because then we can target therapy specifically towards educating and getting them out of what are those maladaptive behaviors as far as their rehab and treatment. So that leads us into advice for self-care, depending on what their response is and what their issue is with how they're reacting. We can inform them, again, generally favorable prognosis. Most people that have this injury that you had are going to get better. It's going to go away. You are going to recover. I make patients say it out loud. I'm like, say it out loud with me. I'm going to get better. Even on the chronic pain, when I would see people with pain for 6 months or over, I would often have them come in, and I'm not going to be their favorite person. I'm the one that jumps around and tries to get them to move around. And I'd say, listen, make me a deal that you'll try this for the first week or two, because what I can tell you is if rest worked, you'd be better by now. You've been on the couch for the last 6 to 8 months and things. You haven't been able to do much, and you're not happy with that. That's why you came into treatment. So if rest was going to make you better, you'd be better. You wouldn't need to see me try this or this and this. We'll adapt it. We'll work with you. You'll modify it, but rest is not going to help you. Advise them to stay active. Again, movement is improvement. Counsel them that hurt and harm are not the same thing. Just because you do something and you're sore doesn't mean you've hurt yourself. This time of year is gardening time for a lot of the area I live in. I'm based out of Ohio right now. We are going to go start raking and shoveling and picking up leaves and all that stuff. And I can guarantee you my back's going to hurt. It'll go away in a week. It'll be all right. But so that's not the same as an injury. Every time you hurt, it doesn't mean you have an injury. Self-care and education books, very, very important. The more self-efficacy or self-education or home programming or those types of things you can do with them, the better they're going to be, not only right now, but for those relapses that are going to occur in 80% or more of people. Superficial heat, not bad, helps with the soreness up and down. Not a lot of significant research evidence on lumbar supports or use of traction for long term. Non-pharmacological therapies. So again, that was the American College of Physicians saying we want to do more self-care, self-efficacy options that aren't medication-based. So exercise therapy, cognitive behavior is getting over that fear avoidance. Focus on function, not just the pain. If we focus on pain as our goal and to get down to a 2 out of 10, that's hard. Pain fluctuates up and down. So if we can focus on, hey, yesterday I walked 5 minutes. Today I'm going to walk 10 minutes. And next week I'm going to walk a half hour. That is something that you functionally can track and control and look at. So putting them on a graded exposure or graded activity program is very, very good for people that have a fear avoidance thing. You're going to feel some discomfort. It's not a sign of injury. It's not a sign that you're hurting yourself. Bear with it. Tomorrow you do better. Tomorrow you do better, and you do a little bit more each day. That's where some of these conditioning and reconditioning programs come in. Again, pharmacology, the NSAIDs or the non-steroidal anti-inflammatories, small benefits. They don't usually hit as much of the high-level pain, but again, low cost. Generally, they're safe except for some GI issues. Again, not much efficacy on acetaminophen. Second line is more your muscle relaxers. You have to be careful with those, especially if people are working light duty or types of things. Antidepressants have been found to be good. Again, they're questioning back and forth effectiveness of some of the anti-seizures, avoiding the benzos. Opioids, again, you have to use with caution, and systemic corticosteroids are not good, especially on a routine or basis. A lot for some things like lumbar instability, there'll be a Medrol dose pack in the very beginning, but then that's not something that they do over and over because it does lead to bone degradation and things. So I told you I was going to give you something that made you smarter at parties. Here is my thing. Again, trying to wake you up about 2/3 of the way into the top. There is a research term called NNT, which is the number needed to treat. And what that is, the NNT is how many people you would need to treat with this specific treatment to get a positive treatment outcome. So whether it be my pain was an 8 and now it's a 2, or I went back to work or whatever. So what they will do when they research different treatments is they will do studies, and then they will develop, this is the number of needed to treat for this intervention. For chronic low back pain, opioids, so your higher level medications that are highly addictive and highly suspect these days, the number needed to treat, so the number of people I have to medicate with opioids to get a positive treatment outcome is 7. It's actually a little north of 7. 7 people I have to drug up in order for one to say they feel better. The number needed to treat for therapy, for physical therapy, occupational therapy, work conditioning, work hardening programs. I need to treat 2 people for one to get back to work or feel significantly better. If you compare those, it's been a long time since I took math class, 7 versus 2, that's really, really good. Do you know how many deaths there were last year from physical therapy? I always have told the American PT Association, we need to put this on the advertisements that we use, is that, you know, we can be 3 to 4 times as effective as drugs. We don't kill you, and you can still use the bathroom. So, and sometimes because we make you move around, you might even get better at it. So again, pharmacological versus conservative care, the number needed to treat is much, much better. There aren't as many side effects. And at the end of the day, it may feel like murder. If you've ever been through therapy, I agree, we could be tough, but we're not going to kill you. So that is important. Other types of treatment, injections, again, have gone up over time, especially epidurals have gotten much more frequently used over the decade. Facet injections climbed as much. Usually they're not as common. Again, epidurals are for that nerve space. Facets are for those muscles, for those bones in the back. For sciatica, there's mixed results with epidurals. Half say they get about a modest benefit, half none. It is short term. It's something that wears off. Mechanical back pain, no evidence yet of injections totally reversing radiculopathy. No reduction in surgery rates and things. So do injections prevent surgery? Not always. Facet injections, again, not always a good impact. What I find with a lot of times injections or facets or those sorts of things, do them in conjunction, do them in collaboration with something. If you're going to do an epidural injection, if it does benefit the patient, usually they're going to feel a lot better for the first week or 2, and again, then they get a reduction. Do that in conjunction with therapy. If they're having a really hard time tolerating any type of treatment or any type of exercise program, and they do have true radicular symptoms, give them the epidural, get them in a therapy program for the next 2 weeks to try to get them up over that hump and get them into something where they can move and start to do better. So a lot of times these on their own, just like any treatment on their own, is less effective. If you can do that in conjunction and collaboration with another treatment, usually it's better. Surgery is kind of up and down. Again, it's happening more and more. This is just on lumbar fusion rates over the 90s to 2001, 220% increase. And then review of the literature, long term, was that really it didn't mean more people were getting back to work. It didn't have a significant advantage over non-surgical treatment, at least in the areas of pain. When you're going to fuse somebody's spine, you're typically going to do it for a safety reason, for a nerve reason, because they are damaging the nerves, and that's going to cause a paralysis or other, again, irreversible nerve effects. So not doing lumbar fusions just because of pain. There are some other pain treatment things that you can do without totally fusing the spine, and those have come a long way in the last few years. So again, a lot of surgeons, these were different things that people had said about how many spinal fusions were going on and those sorts of things, especially doing them earlier on in patients and those sorts of things. So reasonable expectation, again, the more was that somebody asking? All right.
And we do have a question about how long should the epidural last for pain relief, and how often should a patient get them?
You typically, it depends on the physician group and those sorts of things. A lot of times they'll do them in series of 3. If you're going to get a positive response, they'll know right away. After, it depends on how scared the patient is of needles and things. Some people come out and they're like, oh, that was the worst thing ever, and I feel terrible and I hate it, and usually they only get the one because you don't want to force them to do more. The pain management docs that I worked with, we would see people get relief significantly for at least a couple weeks, and it even extended beyond then. Again, we were working with patients who got epidurals and got into therapy right after, and typically we would see good long-term effects with them. So it was more of a conjunction, but you're going to know right away with epidurals, usually within the first day or 2, if they did have a positive impact, and then you want to jump on that and take advantage of it. So it's a I mean, they're putting a medication in there. A medication, just like anything, is going to wear off, but it can help with the inflammation and the swelling, bringing that down. So if you do that also in conjunction, if whatever they're doing to cause the inflammation and swelling they continue to do, then the effects aren't going to last as long. So there are a whole lot of factors that go into that, but you should see a positive effect right away. It should be pretty evident if the patient feels better. And then, like I said, doing that in collaboration with education, how to not stress your spine again, and how to get into mobility and other things that are going to sustain those positive gains is usually helpful.
And second question, so back to MRIs. How long are the MRIs valid? For example, if they have an MRI on file that is a couple years old and they refer for a second opinion or a specialist, should they get a new MRI?
That's really going to depend on the doctor, to tell you the truth, because again, the MRI should be something that guides their treatment decision. So I think the old MRI versus the new MRI, especially if they started working for you a year ago and you have access to an MRI from 2 years ago, snap a new one, see if all the damage that they currently have was what they had 2 years ago. That may actually be beneficial for your claim to have a doctor opine on that and to have that on record. People can have structural change in their spine. If they had a fall 2 months ago, I'd say repeat your diagnostics because you had something significantly happen. So if they had something definitely change and their symptoms changed and whatever, it may be good to repeat it. Again, if you're sending them for a neurologist or a neurosurgeon consult, a lot of times they won't see them unless they've had an MRI within the last 6 months. So I would defer that to the physician based on what they're making their decisions on. And I wouldn't personally sign up for surgery with somebody who said, oh, yeah, we'll go off what you look like 2 years ago. My back might look different when you get in there. So I would defer that to the doctor.
And this is your 2-minute warning.
Okay. Gotcha. So going to talk just a little bit going into recommendations and things, and then we will cut and open. The biggest things that you can do, again, is educate the patient, being aware of what's going on, educating them to be able to treat themselves and things. Passive therapies at this stage, not a lot of value on it. Passive therapy is not going to make you more mobile, not make you stronger. Heating pad, if that makes you feel like you can do more exercise or those sorts of things or mobility, great, but heat doesn't make you stronger. So again, antidepressants and medication should be used in collaboration. Be careful with the opioids and those pieces. You just need to be cautious. Planned follow-up and things, again, be choosy about your imaging studies, and again, if the clinical signs and symptoms make sense for those. Prevention of disability, that is the #1 thing that we think about. Not that I don't want to decrease your pain, but I want to get you back to work. I want to get you functional, preventing that disability. The longer you're off work, the less chance you have of going back. So I need to get you functional. I need to get you back in the door at work. That is my end-all, be-all. I can teach you how to manage the pain, and it's going to go up and down and ebb and flow, but the biggest thing is getting you back to work and getting you functional. That's really where we should look. There's some slides later on this about how effective different things are in per systemic review. When you're looking at treatment, if you have referred people to a therapy type thing, in the first couple weeks, you'll see more passive type things in patient education. Then they should be getting into active motion strengthening, work simulation, functional training. If you see somebody that's been in treatment for 2 months and all they're doing is laying down on their back and getting mobilization and massage, those are the ones that we want to review. We're going to look at those for you, at least for our cases and things. That's when you want to request a clinical review, because they should be getting into strengthening and those sorts of things. So.
Diane, I think you're on mute.
Sorry, I think it muted me. It muted. I think that was the band playing me off and whatnot. But I am done. Again, your resources are there. If you have any follow-up questions, I am happy to address them. But hopefully you learned a few things, and we gave you some more tools in this complex and comprehensive thing. So I will turn it back over to Diane and her team.
Thank you so much for joining us today, and we do appreciate you being here, your expertise. We are going to start our next webinar in about 9 minutes, so we will see those of you that are going to be joining us soon. Again, your certificates will be emailed to you later on tomorrow. Thank you and goodbye.